Re-
Hey, now I can share. So I'm on my Facebook page, which is awesome. And now I just want to share it to the group. Let's see. All right. So we're live on Facebook. We're recording. I know we have some people who are going to be joining us right here through Zoom. So as they log in, we'll add them. So I get to really practice my let's just see how well I can do here. But I'm going to go ahead and just kick this off because I've been super excited about this. So, again, this is Dementia Caregiver Support Program hosting this, but I am super honored and excited to have Sydney joining us from the organization RAFT. With Sydney, you'll talk more about that. But we've had a couple of different workshops and trainings, and of course, you do this all the time. And we find that in our Facebook support group, we get a lot of the same questions, right? Because I keep saying it, dementia is really the great equalizer. So it really just does not matter your background, your expertise. None of those things matter. It seems to be that when it comes to dementia and just understanding and navigating, we all kind of have the same questions and same issues.
Mhm.
So thank you for joining, taking time out. I'm going to turn it over to you to just kind of introduce yourself and talk about what you do before we kind of get into the meat and potatoes of tonight.
Sounds good. Well, thank you so much for having me, and thank you everyone who's joining us on Facebook and Zoom and maybe watching the recording later. So my name is Sydney Palinkis. I am a social worker. I work with the RAFT program. So first, I'll give you a little bit of my background. I have been working with older adults in the field of aging for quite a long time. Originally, actually starting out mostly as volunteer work and working in the violence prevention field. So I did a lot of work with domestic violence, and I worked at an elder abuse shelter for quite a long time. Really enjoyed that work, and then transitioned in the past couple of years to working full time in aging with the RAFT program. So RAFT is a big, long acronym that is hard to remember. I'll tell you, but no need to remember it. It just stands for the Regional Older Adults Facilities Mental Health Support Team. So RAFT is a government program. We're funded by the Virginia Department of Behavioral Health and Developmental Services. The original RAFT program began in 2008 with the goal of serving older adults with both serious mental illness and dementia with challenging behaviors who were unfortunately ending up in the state psychiatric hospital. And then when those folks were trying to return back to the community to assisted livings or nursing homes, there was a challenge. Those communities felt like they weren't equipped to take those folks, or maybe they would say yes, but then they would sort of just cycle back to the hospital because those behaviors weren't managed well. So the RAFT program provides long-term mental health support to those clients. And that program continues on. It's been about 16 years with our clinical team. But there was still a pretty big need for older adults that were staying in the community, staying in their homes. And more support and education was needed to caregivers. So in 2023, we started the RAF Dementia Support Program, which is a free program serving older adults living with dementia and their caregivers in Northern Virginia. And the goal is very similar, kind of like the basics of this program here, just kind of distilled down of educating caregivers, helping them better understand the disease process, helping them better manage challenging behaviors or just challenges in general that come up with dementia. We can help connect to resources because we know that there is a lot in Northern Virginia, which is great, but that can be really daunting and difficult for families to navigate. And then lastly, we can provide free respite care in an assisted living for up to 30 days, giving caregivers a little bit of a break. Sometimes they use that to go on vacation, to go to a family event, or even just to manage their own health needs for that time. So that's a brief overview of Raft and me, and I'll let you take it away.
Well, again, I was just so impressed when I learned about your organization and actually saw your presentation. I've seen a few of them, and always just so informative. And I just love exactly, what you all are doing, and we are even utilizing some of the services. So awesome work. So, as we talked about in preparing for this was really going to be a casual conversation
Mhm.
around dementia and to kind of just answer some of the questions. So, hopefully, those who are joining via Zoom drop questions. Again, this is a conversation, informal. Those that are watching us on Facebook, feel free to share this up to your other groups that, because I'm connected to a lot of people that are in this field. So
Mhm.
definitely, as you're watching this, feel free to leave comments, questions, and all of that. So let's just kind of get into the discussion of what is dementia. And, we chuckle, right? Because there's so much confusion about, I hear people all the time say, I don't know if it's Alzheimer's or if it's dementia. And when they
Exactly.
say that, I immediately am like, oh, this is an opportunity for education. So
Mhm.
I'm calling this my Ask the Expert series. So experts, what is dementia?
Yeah, so yes, I'm also chuckling because that is a really common question. It's a word that we say a lot, and a lot of people we hear it. We hear a lot about Alzheimer's, but then what actually is it? So, dementia is actually not necessarily one specific disease, but it's a collection of symptoms that are related to different diseases or conditions that affect the brain. So, they affect memory, thinking, judgment, language. For something to be considered a dementia, two parts of the brain are actively declining. The condition needs to be chronic and progressive, so it's actively getting worse. So, for instance, that would be sort of the difference between a mental impairment that someone was born with, right? Like a disability in that way. It's not actively getting worse. The brain isn't actively dying. So that would be one of the differences with dementia. And unfortunately, at this point, there isn't a cure for dementia. So when we talk about dementia, it's really this big overarching sort of umbrella term. If you think of sort of the same way we use the term cancer, there's cancer, and then there's many different types of cancer underneath that. So someone could have cancer, but they have specifically, oops, excuse me, my phone fell, prostate cancer or breast cancer. So Alzheimer's, which is where a lot of the confusion comes in, is just one type of dementia. So everybody who has Alzheimer's has dementia, but not everyone who has dementia has Alzheimer's. There's actually over 80 different conditions that can cause dementia. They include, I'm not going to list all 80, and I don't think I could, but there's Alzheimer's, which we all, I think, know the most about. There's also vascular dementia, which can be caused by cardiovascular disease, diabetes, strokes, Lewy body dementia, which looks a bit like Parkinson's disease, but often with Lewy bodies, it's those mental sort of neurological symptoms that come first and then the physical symptoms, while it's the opposite for Parkinson's. Frontal temporal dementia, which affects sort of this part of the brain, the frontal temporal region, which I generally describe it as that's the part of the brain that allows us to sort of look at a situation and say, hmm, is this socially appropriate for me to do? And do I care? And would this hurt other people's feelings? And do I care? Nope. And all of that is sort of damaged. So people start doing pretty socially inappropriate behavior or things that they never would have done before. People can also have mixed dementia, just to make it all a bit more complicated for us. So you could have, say, Alzheimer's disease, and have a traumatic brain injury that causes dementia at the same time. But often, and many of you kind of on this might have experienced this yourself as caregivers, doctors aren't always giving a specific diagnosis. Often, what we're seeing is people just get a diagnosis of dementia unspecified or of what's considered major neurocognitive disorder. And they're not always finding out exactly what type of dementia it is.
Yeah. And I'm glad that you shared that because even in our group, I've seen a lot more people kind of asking about, what type. There seems to be now this again, our group is around 3,100. Um,
Hmm.
and so I know it's a very small population, in the big scheme of things. But I've been seeing a lot more people saying that their loved one was diagnosed with mixed dementia.
Hmm.
Is that something you're seeing is more common? Do you think they're using that just as a catch-all? What are your thoughts around that?
I haven't seen it used too much as a catch-all. I've been seeing more of just unspecified dementia as sort of the catch-all. I think the hard part with dementia is there's no real test for it. There's no way it's not like COVID or TB or something like that where we can just do a test and find out exactly what type of dementia someone has. One of the reasons Alzheimer's is considered the most common is also because we know the most about it. So there actually are some tests they can do to see some of the plaques and tangles that show up in the brain because of Alzheimer's. But otherwise, their doctors are sort of kind of ruling everything else out. It's more of what's called a clinical diagnosis. So they're trying to figure out what is this not? So maybe this is what it is. So sometimes I think they know, okay, well, this person has some of the hallmarks of, say, Lewy bodies, but we also know they had a stroke. So that maybe could contribute to why more mixed dementia. But that's interesting because I haven't seen as much mixed dementia coming up in our clients. So it's interesting that it's more prevalent with yours.
Yeah, yeah. And I'm just gonna just do a quick pause to make sure this is coming through
Sure.
in the actual group. So let me just, we are trying to be tech savvy here. So
Yeah, hopefully we haven't been talking to nobody.
I know. Okay, we're gonna just do a quick pause and see what we have going on here. Let me see. We want to make sure we're pausing for the pause. Okay, let's see. I saw something that did say, I saw something that was like,
I see in the top it says live on Facebook, but I'm not sure.
yeah, so right now it's streaming to my main page and I shared it to the group,
Got it, got it.
but I want to make sure that in the group that they can actually see it. So I think I might have figured out what I need to do. So let
Okay.
me see here. If I give me 1 second. Okay, here we go. We might be getting, where. Okay, so I go to, and thank you for your patience.
No worries. I know how it is. I was a lot of times I do presentations on what's normal aging and what's not, and trouble with technology is a normal part of aging.
I'm telling you. Okay. Oh, it's because that group okay, so um I'm here. While I'm doing this, we do have a question
Sure.
in from Facebook. So she says, my mom has been falling a lot, and I spoke with my manager of my apartment building where I live. She said her mom works for hospice, but I don't think she will qualify for hospice. So how do you know? So if you can, and the great news is we are recording this. So even if for some reason we can't get
Mhm.
our screen right here, but while I'm working on that, if you want to kind of speak to that question.
Yeah, yeah, absolutely. So first off, there is some medical criteria in terms of qualifying for hospice. Generally, it's looking at if the person has an estimated 6 months to live. Now, I will tell you that that is a scary sort of thing to have your loved one qualify for, but often people do stay on hospice much longer than 6 months. It's just sort of estimated. However, I would say kind of depending on where your mom's at, right? Just because she's falling, she might not necessarily qualify for hospice. It is something definitely to check out. I think hospice does feel intimidating for families and sometimes feels like maybe we're giving up, excuse me, if we go on a hospice. But I have never met a family that was sorry they went on to hospice. They're more sorry that they waited. Because hospice doesn't necessarily mean that your loved one is going to pass imminently, but it gives you access to a lot of different services. There's different hospice kind of programs and agencies that you can work with, but they often come with kind of faith support, volunteers, a lot of different services that often come right to the home. But generally, you do have to sort of qualify medically. I would say if your mom doesn't qualify medically specifically for hospice, other kind of things to think about in terms of falls. Falls can be caused by a lot of different things. There's like the obvious ones, the ones that you probably already thought of, but I will say it just for the sake of the group. Some more of the physical things like throw rugs on the floor that can cause someone to slip, poor lighting in the hallway, pets can sometimes contribute to falls. If it's something that's a lot more recent, maybe looking at medications and if there's been any changes there, if there are any medication side effects can cause falls. Um, Also looking at occupational or physical therapy, and that can be really helpful. I've seen that a lot with our clients, helping them better manage some of the things that they do in their day to day and help them keep that strength up, and learn or relearn how to do some things like getting in and out of bed, getting in and out of the shower, and that can also be helpful for caregivers. We all, most of our lives anyway, have not been helping people in and out of the car in that same way or in and out of the shower. And we're often just sort of learning it as we go. But physical therapy and occupational therapy can be really helpful for that as well.
Awesome, awesome. And I think I did just make it available to be seen. So let me just do a quick check.
Awesome.
We're, we're, we are determined to make this work. So let's just see. I love it. Okay, we will continue and hopefully
Sounds
but I
good.
think that was one of the things that I definitely knew we wanted to talk about because we do get a lot of people asking about hospice care
Mm-hmm.
and just I think like you mentioned, and that's something that typically is scary,
Mm-hmm.
before what you think of it, but just understanding like what its purpose is, and I think did you mention palliative?
I didn't know, but I'm happy to talk about
Yeah,
that.
yeah, let's
Yeah.
look at that because I know that can be another kind of less, and I may be misquoting it. I think of it as less severe. Um,
Yeah, yeah. So I think that's definitely a good way to think about it. So palliative care, kind of going back to the umbrella metaphor, um, hospice sort of fits under the umbrella of palliative care. So palliative care is any type of care that you're receiving that isn't necessarily curative. So especially when we're talking about dementia, right? Where we know that unfortunately there is not a cure for dementia. So palliative care can be things to try to keep the person more comfortable, to try to ease symptoms, to try to better support them. So, and palliative care isn't just for dementia, it's for many different types of diseases. And there isn't the time frame of end of life in terms of palliative care. So at any point, someone could decide they're interested in palliative care. I will say there are some programs that offer both palliative care and hospice care. Often, hospice care does come with a bit more wraparound services than palliative care because it's just covered a little bit differently, I think, by Medicare and Medicaid. But definitely something to look into. There's also some programs that I think they're less on the medical side of hospice or palliative care and more on the sort of social services support side. And often for those programs, because it's not medical, they're not billing the same way. It's generally sort of like free support services. They don't have to have like a specific diagnosis or even a specific end of life expectancy. And that can bring in friendly visitors, maybe music therapy, art therapy, all things that are really wonderful and beneficial. Yeah, I personally was a hospice volunteer for quite a long time and really, really loved it. I think, families can't always be there every single second. I personally worked with folks that were in hospice that were living in assisted living. Um, Sometimes people are at home though. But either way, family just needs a little bit of a break and a breather sometimes. So I think as a volunteer, it was incredibly rewarding. And I definitely always recommend hospice care to families if they're considering it.
awesome. And great news, we are live in the group.
Awesome. We
Yes.
made it.
So again, just kind of recapping, and again, the nice part is people will be able to look back on this.
Mhm,
But we talked about first of all what dementia is,
mhm,
and again, and it's interesting because when you described it as replacing that word cancer, I use that all the time with people, and I learned it from one of your workshops. And
Oh,
yeah,
great.
it is so impactful because it's like that light bulb goes off, like, oh, and I often talk about, and maybe you kind of touched on it too, but yes, we can't know definitively in
Mhm,
these cases, right, what type of dementia. But I noticed that a lot of people are saying that their doctors kind of don't even try, right? Like if they get a dementia diagnosis, right? If,
mm,
because, the doctors a lot of times will go with cognitive impairment,
mhm.
that type of thing. But if they get a dementia diagnosis, again, just emphasize how important is it to try to get some idea of what type of dementia that we're working with.
Yeah, that's a really good question. And we've definitely seen that a lot with our clients as well. I think primary care doctors, especially, are very hesitant to make that diagnosis. They're often recommending neurologists. And for folks that are joining us specifically from Northern Virginia, it is hard to get to a neurologist. It can be months and months and months. And that isn't just, of course, one visit. So that's a challenge. It can also be really stressful to of course, be going through that process. I think yes and no. Is it helpful to have a specific diagnosis? I don't think it's kind of the end of the world if families don't have that, but there are differences between the dementias and kind of how they show up. And I think knowing about that can be helpful, especially Things like Lewy body dementia, Parkinson's disease are very movement based, and there are really specific symptoms that are going to show up, and things that you can do specifically to help kind of those movement based symptoms. There are medications that are more specific to Alzheimer's, again, not to cure them, but to help alleviate symptoms, to help maybe slow the progression. So knowing can be helpful. I think in general, dementia looks very similar, especially towards the end. But in those beginning stages and maybe moderate stages, having some idea of what your loved one is facing can be helpful. But you're right, doctors aren't always able to figure it out, or there's some kind of hesitancy, I think, to do that.
Yeah. And I love that you actually talked about stages because that's another question that we get a lot of in our group. How do I
Mhm.
know what stage my loved one is in? Are they in stage 5? And they have these questions. So can you give some guidance on that?
Yeah, so I think the stages are hard, especially because there's a lot of different models of the stages. The there's like the many stages. I think it's like 8 total stages. Some people just kind of go by early, middle to late.
Mhm.
There's also the GEM model, if anyone's familiar with that, by Chipa Snow, which looks a lot more at the strengths that people have retained still and less at what's been lost. So I think it's hard to really look at the stages and know always exactly where someone is, especially because things are very different day to day or even within the same day, right? Dementia has like the structural components of the brain that are affected, but there's also chemical changes which can cause these kind of variations, and that can be hard. I often if families sort of want a little bit more of definitive answer on stages, look a bit more to just the early, middle to late and kind of what that looks like. I'm happy to, would you want me to kind of go through that a little bit?
Yeah, if you don't
Yeah.
mind. Yeah.
Yeah, absolutely. So early stages, there's there's less sort of interruption in daily life. People are often able to still be fairly independent, maybe still driving, maybe just needing like a little bit more support. Finances is often one of the first big things that people have trouble with. Finances is like a lot of complicated thinking, except for those of us that are incredibly great at math and maybe like have those inherent skills. But in general, that's one of the first things to start to decline. So needing help with that, having trouble sort of paying attention, having trouble making decisions. And again, not sort of life stopping trouble, but just sort of starting to notice more of those disruptions. Maybe having more trouble remembering names, and not just remembering names, but even someone that we see often reminded of their name, and we still kind of take a moment to remember who that person is even. That's kind of often those beginning stages. I have a loved one living with dementia, and one of the beginning things for him was he was losing things a lot. He was losing his wallet, he was losing his keys, because he was having trouble retracing his steps. And in the beginning, sometimes it's hard. Sometimes family isn't always picking up on that there's a problem. The person isn't always picking up on that they're having a problem. Um, so it can be sometimes frustrating for loved ones because we're thinking, what's going on with you? Why are you missing things? Why are you losing stuff? Why are you maybe not pulling your weight in the house kind of the same way that you used to? So those can be some of those kind of early signs. Middle to moderate stages, all of that kind of gets a little bit worse. So communicating becomes more difficult. People might start having trouble a lot more with nouns. So, the words for places and people and objects become difficult, but they're still able sometimes to sort of come up with a version of the word. So for instance, they maybe forget mouthwash, but they say, well, we need to get mouth shampoo from the store, right? Their mind is kind of able to get there a little bit. Um, a little bit less difficult, or a little more difficulty kind of making plans, maybe starting to need more sort of cueing. So, I can still get dressed on my own, but I might need some reminders of sort of what to do in the next steps. And as that progresses, more and more reminders and more sort of cueing on those things. People often in that moderate stage are sort of stepping back a lot from the things in their lives, maybe not doing as many hobbies, sort of socializing less. And sometimes that's because of the embarrassment of feeling like, oh gosh, I don't want to go there and forget people's names, or I don't want to kind of embarrass myself by talking and forgetting what I'm saying. But it could also be due to those kind of mood and personality changes. There's a lot kind of going on in the brain at that point, and that is just really overwhelming. So people are, getting a little bit more irritable. They might at that point start experiencing some paranoia, some hallucinations, and some delusions. And some of those are due really to the structural changes that are happening in the brain, kind of causing people to see things that aren't there, hear things that aren't there. And some of that is what we call confabulation, where people are trying to sort of make sense of the gaps that they have. So, for instance, let's say I'm driving, maybe I shouldn't be driving anymore. When I come home, I miss the driveway because my vision is impaired more at this point, which happens with dementia, and I park more in the lawn. The next day I come out, I don't have a good memory of doing that, and I think, oh my gosh, why is my car in the lawn? Somebody must have taken my car and moved it. And now suddenly I kind of have this story in my head, that because I'm trying to make sense of those things. So that's something that happens a lot in the moderate stages. And we can talk all about sort of delusions and some of the common ones there. Um, but more in the late stages, again, all that's going to progress. Language really decreases, and people start speaking less and less and less. Even to the late stages, people might still be somewhat verbal, although I've seen folks that are almost completely nonverbal, except when really sort of prompted or something sort of sparks them. Like music can be really great for that. They are having more difficulty not just getting language out, but also understanding it. So as we're talking to them, they're less likely to kind of pick up on the things that we're saying. There's, of course, a lot more difficulty of understanding kind of where they are in time, or where they are in their life. So, are their children young or are they old? And, have they been sitting in this chair for 2 hours or has it been 5 minutes? All of that kind of gets much more confused in the brain. And then, really, if we think of all of the things that the brain does, and this is sort of hard to think about when we're caring for someone with dementia, but all of those things start to fail. So, memory and judgment and language are all kind of the big ones with dementia, but eventually it's, regulating breathing, regulating digestion, regulating heart pressure, all the things that our brain does, which is everything, will eventually start to fail, which is ultimately why dementia is terminal.
Yeah, yeah, that's really tough. I do want
Mhm.
to address a few things.
Yeah.
So the one thing was, because we weren't showing up in the group, if you don't mind, the question regarding, if you could just repeat that answer regarding the question. My problem is my mom has a new neurologist and he wants to do an MRI of her head to do his own diagnosis, but hospice doesn't want her to do it. Okay, so actually that was a response to the other question about hospice care. So if you could
Okay.
just again kind of talk about the hospice piece, if you don't mind. Just again, like when is a good time to think about using that? What's
Mm-hmm.
the real benefit? And again, see, MRI had to do his own diagnosis, but hospice doesn't want her to do it. So just you can provide maybe just some thoughts or opinions around that, and then we'll go to the next question or the next comment that the person had as well.
Okay, sure. So in general, hospice is for folks that have an estimated of 6 months left to live. And as I said before, that is a scary thing to have your loved one qualify for, but it doesn't necessarily mean that they are going to pass in 6 months. I've seen a lot of folks, and I've volunteered in hospice for a while, who were on hospice for a very long time. I had a patient that I worked with for over 2 years on hospice. So that timeline can feel scary, but it's not always quite as finite as maybe it seems. Hospice is really for anyone who there isn't a cure necessarily for their disease, or maybe they're kind of stepping back from that cure and want just more comfort measures. And hospice comes with a lot of different supports. So I personally really love hospice. I think it's so beneficial for families. It often comes with spiritual support, social workers, case managers, medication management, volunteers. There's a lot that comes with it. And again, in terms of timing, of course, your loved one has to sort of qualify in that way, but very rarely are people sorry that they started hospice. They're generally sorry that they didn't start it sooner because of all the things that it comes with. And understanding that it is a lot and it's overwhelming to have your loved one qualify. But there's a lot of support, not just for the person, but also for the caregiver and the family. There's often grief support available with hospice kind of pre-passing and after. So a lot of support for families. So I think if you're thinking about it, it's definitely worth pursuing. And trying to, as much as possible, to learn more about it and sort of demystify, sort of stigmatize hospice, because it's just a really great resource for families, honestly. And then the MRI question specifically, it sounds like they're already on hospice, but hospice is saying they don't want the MRI. And that might be because if their hospice is looking at the MRI as kind of treatment of the disease. My guess is perhaps that that's how they're viewing it, and hospice is often just sort of helping with the symptoms. So if they already know that they have dementia, what is the goal of the MRI? And again, I'm not a doctor, so that is my understanding of hospice and sort of the medical piece of that. But definitely something to explore. And I will also say, you can be on hospice and then exit hospice. So if enroll your family member in hospice and this is like not working for you, or if suddenly some wonderful medication came out that you wanted them to be part of, you can always unenroll. I'm not sure the word for that, but kind of exit hospice. And there are people sometimes who kind of graduate out of hospice. Their lifespan is no longer 6 months, and doctors say, they don't qualify anymore. So there's a kind of a lot to explore, and it's a lot more flexible than I think people realize.
Yeah. And I think that's so good that how you explained it, because I saw there was a post today in the group where someone was saying their loved one was going on hospice, and they talked about the guilt, the guilt that they feel.
Mhm.
So I love how you broke that down, because if you think about your loved one, as you mentioned, maybe that 6 month, time span,
Mhm.
um, it you could almost look at it like not getting them maybe the comfort care is more harm than good, right? So I
Mhm.
think how you explained it, if that is the place that your loved one is in, it can
Mhm.
be very helpful to help just minimize some of the guilt. I mean, everyone always talks about, sometimes when we have new members, there's a number of members who will say, welcome to the group that no one wants to actually be a part of, right?
Yeah.
So
Yeah.
I think that's worth saying. Like, I don't think anyone's going to ever just be like, yay, I feel so great.
Yeah.
But if you can kind of have, just a measure of peace in knowing, and I say it all the time, parents have to do this for their kids, all the time, right? Like,
Hmm.
growing up, surgeries, there are kids who hate school, but parents are like, you are going to go to school. I cannot let you not go to school. So, in this disease, we kind of switch roles a little bit and we have to make those tough, hard decisions when we know what's best for our loved one, when they can't make those decisions for themselves.
Yeah, absolutely. And I think I don't mean this to sound harsh in any way, but and also thinking about hospice and maybe getting rid of some of that guilt is, the disease is kind of going to be what it's going to be, right? And we can either bring in more support and help, us as caregivers and our loved one as much as possible, or not. And I think, that is a really great tool to use, if it's available to you at the time. So that time frame is going to be whatever it is. So if you qualify, really being a hospice cheerleader here, but
Oh,
as a volunteer for such a long time, I think I really saw the benefits of it. And it's really, really helpful for families. And there's a lot of different agencies that offer hospice. So, if one's not a great fit, there's definitely others.
yeah. And we had a comment too, where she says, my mom just sits and stares if I ask her to get dressed. And she says, this is new. So I
Mm.
know, as you mentioned, you're not a neurologist giving
Mhm.
medical advice,
Yeah.
but just what feedback would you provide for that as an expert in the field of this? What things would you encourage her to do with this new symptom?
Yeah, so that's a really good question. So there's a couple different sort of things to think about, and whether it's getting dressed or any sort of situation where a loved one with dementia is sort of stalling, right? They're not stalling like they're meaning to stall, but they're not able to sort of get going on whatever that action is. Sometimes it's they don't know what the steps are. So we're saying, okay, get dressed. Do they know where to go? Do they know, okay, I need to walk to my closet and I need to take off what I'm wearing now and put this on? And sometimes those steps might need to be broken down a lot more. And it could be kind of walking them through each step of, okay, mom, let's go to your bedroom. Why don't you open the closet, and really kind of breaking it down step by step by step. For some people, it's kind of the decisions that's difficult. So maybe mom knows what to do, but there's a whole closet full of clothes, and looking at all of those options can be too overwhelming. And that's definitely something we've seen specifically with getting dressed, with clients, where it's hard for them to sort of figure out, okay, what am I supposed to wear? And I don't, especially if like time and place is off, right? I don't even know if it's going to be cold. I don't know if it's hot. There's too many factors.
Yeah,
I've seen families before, in order to give their loved one more independence, and help them kind of keep that dignity of the things they are still able to do, they empty the closet except for one or two outfits. So, mom or dad is able to go to the closet and choose what they want, but there's really just kind of one choice. So they have that kind of power. They feel like they're in control, but they're not stalled out by the lack of choice.
yeah,
Um, I think there are certain types of dementia where looking at a situation and being able to kind of plan the next step is especially hard. So vascular dementia is one of those where it's really difficult to kind of make the next decision. So that cueing can be really helpful. Sometimes reminders. So maybe you're not able to be there every second while someone's needs to get dressed. But whiteboard reminders, of, open your closet, choose a shirt, choose your pants, whatever those steps are going to be and however broken down they need to be for your loved one. Sometimes spelling them out can be helpful. I know in Arlington Adult Day Program, I'm sure they have this in other places too. In the bathroom, they actually have visual signs that tell you the steps of going to the bathroom. So it says, close the door, pull your pants down, like literally all the steps visually. And that, is very helpful for folks who get in there and think, okay, I don't know what to do, but I also don't really want anybody in here with me, right? So how can I still do this on my own with some cueing? I will say if changes are very sudden and very drastic with a loved one, going to the doctor is really important because it could be something else. It's not always just the disease progressing or changing. Urinary tract infections are a huge one that we see, can cause really big changes, medication side effects. So if it's brand new, really drastic, definitely getting that checked out is important.
And I'm glad you said that because she also, it looks like while we were talking, she said that her mom sees snakes in the living room and bedroom. So it definitely, I think you were spot on that it sounds like this kind of new, more significant changes
Mm-hmm.
we need to be really talked about and analyzed. And I love that you said that because I know in one of our other workshops, we had Dr. Lamb on.
Mm-hmm.
And I know, if not in that one, in another one I attended, she talked about medical bias. And unfortunately, I mentioned earlier, my new thing is dementia is the great equalizer, right?
Mm-hmm.
Unfortunately, where we see a lot of negative just response and reaction is that the bigger crisis is on aging, right? Because
Mm-hmm.
typically this is something that's affecting older individuals.
Mm-hmm.
And I personally can't stress enough to be your loved one's advocate. I mean, I don't want to discount the whole medical field because we do need them, but I just have seen it so much where these
Mm-hmm.
doctors, neurologists have been very dismissive. And, well, your loved one has dementia. So what do you expect?
Mm-hmm.
Things like that. And to your point, there's an adverse reaction to a medication or a UTI or something else going on. So, I mean,
Mm-hmm.
I could spend a lot of time just on that itself. But what is your feedback on that piece?
Yeah, I think that's absolutely the case. I think I've heard a lot of family who are concerned about specific symptoms, and not necessarily saying maybe, I want you to cure this, but, is this normal or what can we do about this? And how do I respond to this with my loved one? And sometimes I'm with you. I don't want to dismiss the whole medical community, but they're working kind of in a much faster paced world than social work and those of us and kind of the social services. Sometimes it is just okay, well, they have dementia. And let's kind of keep it moving. And sometimes I think even just the general symptoms of dementia, person's just older. So really, I think knowing your loved one and being able to advocate for them is so, so important, especially in those early stages. So they're able to kind of tell you what are the things that I want moving forward. And those conversations are difficult to have for sure. But I always try to talk to folks of, maybe you'll never need this. Maybe we'll never get to this point. But if we do get to a point where you aren't able to tell me what you want and what's going to comfort you and what's going to drive you crazy if I do, I want to know now so I can advocate for you in the future. Because I think doctors all get sort of a run through of dementia, but in the ER and things like that, it's a lot, and people aren't always thinking through the lens of how is this going to be best for someone with dementia. So unfortunately, family does have to say sometimes, okay, I need you to talk to my loved one, not just look at me. I need you to break that, just grab them and do the blood pressure, and really, really kind of treat them with that respect and dignity, knowing what the dementia, how it's kind of changing their viewpoints.
Wow. So I think as we kind of, come start kind of wrapping it up a little bit for this conversation,
Hmm.
um, dealing with just the difficult behaviors, and you have a whole workshop. So
Hmm.
again, I know most people will be watching this after the fact. Uh,
Hmm.
I'll make sure to have your link. I don't, do you actually have those presentations like somewhere where a person can click on them?
We don't have them all up. No, we actually did just do a webinar on challenging behaviors. So I'm happy to share that recording with you. I think it has to be shared individually just due to like the rights of it on the link. But yeah, we also do the trainings for anyone who's interested, and we do one-on-one consultations all the time as well.
Okay, so maybe a few words, and then what we'll do is we'll just plan maybe our next. Look, I'm gonna I'm gonna just enjoy using your services,
Yeah, please do.
but maybe we'll do our next one. We'll kind of run back again on difficult behaviors.
Okay.
Um, as I was looking, I was seeing some posts are coming through. It's hard. It's hard
Hmm.
when your loved one has the difficult behaviors, and you're navigating other family members. So,
Hmm.
what are just some words of encouragement that you can give for those with the difficult behaviors?
Yeah. So I think a lot of the challenges with difficult behaviors, it's all a lot easier said than done, right? And really, as much as possible, trying to remember that these things that are happening because of the disease. They're not happening because, our loved one is kind of trying to drive us crazy, or they're suddenly a terrible partner or a terrible parent, or not kind of caring about how we feel. That it really is these changes in the brain. And that is hard. That's hard to, sometimes we know it, but it's still difficult when our loved one is kind of cursing at us, or maybe not doing things that are nice, or even getting kind of physically aggressive. So knowing that, but also knowing that it's okay to focus on your own sort of safety and mental health as well. And it's okay to kind of take that break, step out for a second and breathe. Oftentimes when people are doing what we call kind of these difficult behaviors, is they're trying to communicate something is trying to be communicated, that they're not verbally able to do that anymore. I kind of always use an example of, if I'm sitting here and I'm saying, okay, my dress is kind of getting itchy and it's hot and I don't want to be on this call anymore, I really want to go to bed, but I'm not able to verbalize that. That might come out as me cursing and me pushing my laptop over, and all of these sort of behaviors that then make caregivers frustrated. And we think, oh my gosh, what's going on? You were sitting there all fine 1 second ago. And right, we have to sort of be detectives a little bit sometimes, which can be hard when you're doing it sort of day to day. But learning your loved one's triggers can be really helpful if there's certain things that make them agitated or make them anxious. And as much as possible, remembering that logic is often sort of out the window with dementia. So we can't argue with these things based on logic. It's not going to work. We have to focus so much more on emotion. So, what is the emotion behind that?
Mm.
Example could be if, I'm caring for maybe my mom with dementia, and she's saying, someone's coming in and they're taking all my stuff, and I think you're part of it. It would be really easy. And what I'd probably want to say is, Mom, that's not happening. All your stuff is here, you know, none of that's happening. But that's not gonna be helpful, right? And if we sort of think of it from her perspective, if I was coming in and stealing stuff, of course I'd say I'm not. So that is just like, it's not very convincing.
Right.
Um, so focusing more on the emotion, right? Like, Mom, that sounds really scary and really frustrating. I want to make sure your stuff stays safe too, and that you stay safe. Let's figure out how we can do that because I can tell that you're really scared."
Yeah.
And really focusing much more on emotions is helpful. It's hard, and all of that is hard, but also just kind of choosing your battles, right? There's things that sometimes our loved ones do that are frustrating and maybe annoying and maybe not great, but not necessarily a safety issue. So does everything have to be corrected, or can some things kind of let it go? Yeah, but I could talk about this all day, and I think there's definitely tools caregivers can have that can help either de-escalate or escalate those situations, and that's a big thing that we work on in the program.
Yeah. And we'll definitely have you back. I think the only thing that I would add to that is something that I even just kind of had to learn and tell myself.
Mm-hmm.
So we, even when we talk about parents, right? Like parents, they get to watch the progression, right?
Mm-hmm.
And it's filled with just like excitement and joy and all of those things.
Mm-hmm.
There's also a lot of times training and education and all these things that you can get. When it comes to this illness, I think it's probably safe to say like none of us, right? Because I've spoken to even doctors and people in the field, and it's like when it's your loved one, you are
Mm-hmm.
just as much, out of the loop as any common person. So,
Mm-hmm.
I would add, if you think about who you are, right? This is kind of how I've tried to look at it. There are
Mm-hmm.
some things about myself that I don't necessarily like. Like different behaviors that I have that I know I can, get an attitude about this or that, right? But
Mm-hmm.
I have the cognitive ability to filter that out. So I can be in situations that totally upset me. And in my head, I might be saying a lot of things, but I have that ability to filter that.
Mm-hmm.
Imagine the worst parts of you where you are not able to filter that,
That's
right?
such a good way to think about it.
Yeah. And it's like when you think of it that way, what I would add encouraging caregivers, number one, do the best you can. You're
Mm-hmm.
not going to be able to get it right all the time. You are going to get just as frustrated and sad and irritated at someone yelling at you or accusing you
Mm-hmm.
because you're human. But I also would say, and feel free to correct me if I have the wrong viewpoint on this, but I also look at it like there comes a time when you may have to make that decision if it's too much for you,
Mm-hmm.
right? And I
Yeah.
even saying it feels like, oh, that feels so bad to say. But speak on that. I mean, what
Yeah.
you
Yeah. I'm
you're dealing with someone who's unfiltered and they are just like aggressive and
mm-hmm.
hurtful and is creating depression in you. Like, don't you agree that there's a time where maybe you say, I can't do this?
Yeah, I think I'm really glad that you brought that up because it's really difficult to make that decision for folks. And I've especially, and this is just sort of my experiences in the work, but seen spouses especially have a hard time with that, who they're really underplaying some of the damage that's happening to them. Physical damage, like physical aggression. We've had caregivers who they've had broken bones, like really, really serious things. That kind of not even including that, the mental toll that it can take caregiving and experiencing kind of that constant barrage of aggression and verbal aggression is something we really need to kind of take into account, to be there for your loved one and be there for yourself. We've had caregivers who've called us and said, I've been through my own trauma in my life, and this is triggering that. Or, I didn't have a good relationship with my mom or my dad before this. I don't know if I can do this. And I think that that's okay. Especially you don't want to get into a situation where you're burning yourself out, and we talk about caregiver stress, but there's also caregiver distress where you're turning to alcohol, you're turning to other substances, or your finances are really getting hurt and you are hurting yourself by caring for someone. And it's a service to you, but it's also a service to them to kind of know when to step back. There's a really great book. I'm not sure if you've read it, Lita, by Dr. Blight. He talks about caregiving, caregiving kinetics, I believe is his company. But one of the things he talks about is the different roles that we sort of take as caregivers. And now we all have sort of different privileges in how much we're able to do this or not. Um, but knowing when sort of that role change is too much for you. So, the role that, you take with your parent when everybody's fine and nobody's sick is very different as that disease progresses and that really changes. Most of us normally don't take our parent into the bathroom and help them in there. And that might be sort of the line where we say, I want to be able to be with my mom and have fun experiences with her, but not do this piece because I can't take that on. And I think that's really okay. I think to say this is my max, and I'm gonna set up other services so my mom, of course, can get that care, right? But it doesn't always have to be me. It doesn't always have to be taken on by me.
Yeah. Wow.
Yeah.
That is powerful. Well, I thank you so much for your time. I believe you're going to be at our November event. I know it's either you or your or someone from your organization.
Yes, yeah. So my colleague Narisha is going to be there. Yeah, she's wonderful. She's really excited.
Awesome, awesome. So I will say then after that, hopefully we can get together. Like I said,
Mhm.
I'm just going to keep tapping your
Please
shoulder.
do. Yeah, this was great.
But it's so, I mean, you're so informative, you get it. And so I love just hearing you talk and explaining. And there's so many, like I was checking out your different presentations, like
Mhm.
there's so many topics that you cover. So I encourage if you're in the Northern Virginia area, and I know it's very specific as far as zip codes that RAFT covers, correct?
It's all of Alexandria, Arlington, Loudoun, Prince William, and Fairfax.
Okay, okay.
So anything in that region, yeah. So I mean, for if you look at all of Virginia, it's small, but pretty
North,
big,
that's
pretty
pretty.
big area. Yeah.
That's awesome. So, and I've told a few other folks about you too that are in the industry, some home care agent folks. So, again,
Perfect.
whenever you're watching this, if you're in the Northern Virginia area, in those areas that were just mentioned, and of course, I'll have the information too there. Click on the link. One of the services that they have that we just recently took advantage of is they actually have someone that can come to the home, sit down, talk with the family, talk about the needs, and then provide resources.
Mhm.
We were able to find out that lo and behold, we could get some vet benefits because my stepdad is a vet. So you just sometimes you don't know what you don't know, right? So
Mhm.
if you're in the area, and then do you have connections with people outside of the area that, like, if someone is looking for help, maybe they can still, like, maybe you can refer them out to others or something like that?
Yeah, there's not necessarily like a same comparable program in different areas. DC, there's a program that's fairly similar. Sort of depending on where they're at, will depend on how comparable the program will be. But we definitely have different connections that we're able to connect people with.
Awesome, awesome. Well, thank you again. Enjoy.
Thank you so much. This was great. I'm definitely happy to come back again, answer more questions, and hopefully people will find this useful.
Awesome. Thank you so much, Sydney. And thank you all for tuning in again, even after the fact. And we'll be bringing more. We'll be bringing more of this because it's so helpful. All right.
Thank
We'll
you.
take care. We'll talk to you later.
Sounds good.